If you leave an ACL deficient knee unstable for too long, the medial meniscus often pays the price. Welcome to the Sunday Paper Roundup, where I read the paper so you don't have to. And this week I'm looking at a paper fresh out of the American Journal of Sports Medicine, one of the premier journals in the world for sports injuries and treatment. And it looks at a very practical question. How long can you leave an ACL deficient knee before the risk of meniscus damage starts to rise? The paper is by Nickelberry and colleagues, just published out of Portland, Oregon. I knew that Portland is where Nike are headquartered, but I had no idea that Adidas North American HQ is there also. So I decided not to pick any sides and represent the UK in my Gymshark. Right now it feels it's just me and Central C representing. Anywho, this was a multi-center retrospective cohort study of over 2,000 patients undergoing ACL reconstruction between 2013 and 2023, aged 9 to 73. 73? Yeah. And the key finding was this: delaying ACL reconstruction beyond 120 days was associated with a significantly higher prevalence of medial meniscal tears and combined medial plus lateral meniscal tears. The analysis showed that surgery after 120 days increased the odds of medial meniscal tears by 80% and combined medial and lateral meniscus tears by 47%. Being male was also associated with higher odds of all meniscal tear patterns at every time point, regardless of delay. That is the headline. Why does this matter biomechanically? Well, the paper rightly reinforces something I feel that too many non-surgeons still really underestimate. The medial meniscus is a secondary stabilizer of the ACL deficient knee. That's not just an academic point. If the ACL is injured, the medial meniscus ends up taking more of the load in resisting anterior tubular translation. Over time, that can become attritional tearing, especially in the posterior horn. And this is where the clinical message matters, because non-operative management is often framed as though it's the safe option and surgery is the risky option. That is too simplistic. Now listen, how many times do I have to say that not everyone needs surgery? Not every ACL deficient knee spirals into disaster, and I'm absolutely not anti-rehab. But let's be clear, ACL deficiency is not a benign state if instability persists. Check out my Sunday Paper Roundup from the 8th of February, where I reviewed multiple papers showing that patients having ACL reconstruction have a lower risk of osteoarthritis needing knee replacement in the future than those treated non-operatively. As someone who deals with the consequences of post-meniscal deficiency every week, cartilage overload, meniscal deficiency, osteotomy, joint preservation, early arthritis in younger patients, I can tell you that this is not theoretical. A lot of people who do not operate simply do not see that end of the pathway often enough, if at all. What do they find? The authors divided patients by surgical timing, and the signal emerged clearly beyond 120 days and then plateaued. Further delay didn't compound the risk linearly. That's a genuinely novel finding, validated by analyses subdividing the delayed group. The pattern actually makes biological sense. Lateral meniscal tears are often part of the acute injury event. Medial meniscal tears, especially in the posterior horn, accumulate over time as the unstable knee keeps translating and rotating abnormally. Different pathophysiology, different timeline. But this paper does not sit alone. Within the evidence, it sits in a large and converging body of structural outcomes data. The New Zealand ACL registry, nearly 16,000 patients, found medial meniscal tears in 40% of patients operated at 6 to 12 months, rising to 53% beyond 12. Different population, same direction. The AAOS updated their clinical practice guideline in 2023 regarding timing of surgery from 5 months down to 3, based on exactly this accumulating structural evidence, and this paper further validates that position. And there is a finding from the wider literature that this paper does not capture directly, but which I think deserves to be said clearly. It is not just that delay makes meniscal tears more likely, it makes them less repairable. Research published last year showed that meniscal tear repairability drops from 57% before 5 months post-injury to just 19% after 12 months. A meniscus repair preserves the tissue, preserves the joint. Where a tear cannot be repaired, you're removing something that does not grow back. And this is where the long-term joint degradation begins. I'm not reviewing the RCT functional outcomes data today, that's a separate video. But in one sentence, functional equivalence at 2 years in the randomized trials measures patient-reported outcomes at a short time horizon. It is not measuring structural meniscal integrity over a decade. And those are not contradictory findings, they are answers to different questions. Let's look at the critical analysis. What does this paper get right? It's a large sample size, multi-center, intraoperative findings rather than imaging alone. The 120-day signal is really clinically useful, not as a magical deadline, but as a clear message that allowing an unstable knee to drift for months is not consequence-free. But we should not overstate it. Let's be honest, this is a retrospective study, association, not causation. The injury date was partially patient-reported, introducing some recall bias. There's no control of what happened during the waiting period, no quantification of instability, no rehab quality data, and no activity exposure. And critically, the paper tells us about prevalence of meniscus pathology, but not the severity, not the repairability, not the tissue quality. A small stable lesion is very different from a bucket handle tear, a root tear, a ramp lesion, or a chronic irreparable posterior horn tear, and that distinction is absent here. The sex finding also clashes with some prior work. A study in 2023 found elevated female risk beyond 24 months. That discrepancy is unresolved and needs its own research agenda. Now, this study does not mean that every patient should now have an urgent ACL reconstruction. That would be a really crude interpretation. Some ACL deficient patients can cope very well. Some can be managed non-operatively. Almost all, in my view, need a period of rehab first anyway, and some have good reasons to delay. So the real take home is not all ACLs need immediate surgery. It's this: if the knee remains functionally unstable, delay carries risk, and one of the structures most at risk is the medial meniscus. And it matters especially in younger athletic patients, male patients based on this study, and anyone with repeated giving away episodes. Because once the meniscus is gone, it's gone, and the whole joint changes, and that is where the preservation problem starts. My bottom line: I think this paper is a useful corrective to the increasingly casual way some people talk about non-operative ACL care. Again, not everyone needs surgery, not every ACL tear needs reconstructing, but non-operative care is not zero risk, and instability has a biological cost, and that cost is often paid by the medial meniscus first. So what's my verdict? Should you ignore it? Should you be aware of it? Should you consider it? Or should you go ahead and change your practice? My verdict: go ahead and change your practice. Not by operating on everyone, not by rushing to surgery, and not by abandoning shared decision making or ignoring the rehab literature, but by being much more honest in your counseling that persistent ACL deficiency is not benign, and prolonged delay in an unstable knee increases the risk of medial meniscus damage. And once that meniscus starts to fail, the long-term price can be much higher than many people realize, including many healthcare professionals. 4 months, not 12. The medial meniscus doesn't wait, and neither should the referral. I'll see you next Sunday. I'll keep breaking down the evidence as it lands.